Okay, welcome back. This is Senate Health and Welfare, and we are turning our attention to S204, an act relating to licensure of freestanding birth centers. Our legislative counsel, Jen Carby, will go through the bill with us first, and then we'll hear testimony. And I'm going to ask if there is anyone who has an urgent need to go first, has a pressing schedule. Everyone has a pressing schedule, but okay. All right, good. And I don't necessarily think we'll go through the list of witnesses in the order that they're on the agenda. I will space it out a little bit. So Jen, why don't we go through the bill together?
Good morning, Jennifer Carby from Office of Legislative Counsel. I've put the bill up on the screen. Let me know if you cannot see it. Otherwise, I will take you at a fairly high level through the bill. It is S204, an act relating to licensure of freestanding birth centers. And this would create a new chapter in Title 18 for licensing birth centers. The language in this chapter is very similar to language that was adopted by the legislature, enacted by the legislature a few years ago for ambulatory surgical centers. So just to give you kind of a frame of reference, that one started out based on the hospital licensing statute and chapter ended up being narrowed a bit. The scope of it was narrowed a bit. And so this is based on that. There's just a lot of provisions in hospital licensure that don't apply to other types of facilities. So it starts out by defining a birth center as a facility that is not a hospital or part of a hospital at which births are planned to occur away from the pregnant individual's residence following a low-risk pregnancy, and that provides prenatal, labor and delivery, or postpartum care, or a combination, as well as other related services in accordance with the scopes of practice of the healthcare professionals who are working there. It prohibits establishing, maintaining, or operating a birth center without getting a license. It sets out the application and fee for licensure. So this would go through the Department of Health. The application would have a licensing fee of $300, which is half of the amount for the ambulatory surgical center. And then it does have a unique provision here saying, notwithstanding anything to the contrary, for an application to renew a birth center license, so not the initial application, but the renewal, the health department shall deem a licensed birth center that is currently accredited by the Commission for the Accreditation of Birth Centers or another accrediting entity that complies with the National Birth Center standards published by that association. They'll be deemed as satisfying the requirements for renewal of the birth center's license once they submit a copy of their official accreditation certificate and payment of the application fee. So initial license would have to go through the health department process, but a renewal could be could be deemed renewal licensure based on accreditation by one of these national centers. So then it talks about the requirements that a birth center must meet in order to be issued a license. So it has to demonstrate the capacity to operate a birth center in accordance with health department rules, demonstrate that the facilities comply fully with standards for health, safety, and sanitation, including those set forth by the state fire marshal and the Department of Health and by municipal ordinance. They have a clear process for responding to patient complaints. They have to participate in the patient safety, surveillance, and improvement system established in existing state law, and the facilities, including the buildings and grounds, must be subject to inspection by the department and others at all times. Licenses only for the facility and the persons who are named in the application. There's a process that's the same as the revocation of licensure process for hospitals and for ambulatory surgical centers, and also the same appeal process. It would require the Department of Health to make or cause to be made inspections and investigations as deemed necessary. And if the department finds a violation, to post a report on its website summarizing the violation and any corrective action required. There's some provisions around records and how information would be or would not be disclosed. So information received by the department through filed reports, inspections, or is otherwise authorized by law would not be disclosed publicly in a manner that identifies or may lead to identification of one or more individuals or birth centers. They would be exempt from public inspection and copying under the Public Records Act, and they would be kept confidential, except as they relate to proceedings regarding licensure. However, those confidentiality provisions would not apply to those summary reports of violations to be posted on the department's website. And this, again, is all consistent with what you have for ambulatory surgical centers and hospitals. And it would direct the health department to adopt rules as needed to carry out the purposes of the chapter. The rules must regulate birth centers in accordance with national birth center standards published by the American Association of Birth Centers, and may include provisions on the scope of services that can be provided, appropriate staffing, including the types of licensed healthcare professionals who could practice at the facility, and a requirement for written practice guidelines and policies that include procedures for transferring a patient to a hospital if circumstances warrant. So that is the licensure piece. Section 2 would specify that health insurance plans providing maternity benefits would also have to provide coverage for prenatal, maternity, postpartum, and newborn services provided at a birth center. It would have Section 3 is an exclusion from the certificate of need statutes for birth centers. So it would not require a certificate of need for a birth center, would include birth centers in the list of types of practices and facilities like physicians, dentists, and other practitioners of healing arts, so individual provider offices. Section 4 directs the Agency of Human Services to seek approval from CMS to allow Vermont Medicaid to cover prenatal, maternity, postpartum, and newborn services provided at a licensed birth center, and to allow Vermont Medicaid to reimburse separately for birth center services and for professional services. And finally, it would take effect on January 1st of 2023, except it would direct the Agency of Human Services to submit its request for Medicaid coverage to CMS by July 1st, and the Medicaid coverage would begin on the later of the date of approval, or January 1st, 2023. That is the language of the bill.
Okay, questions for Jen for clarity? Senator Hooker.
Thank you, and thank you, Jen. I'm wondering about the relicensing, and you talked about the center not having to go through the whole process if it was accredited with the national birthing centers. And is that something that happens automatically on the initial licensing, or is there a process that has to ensue after that once the center is established? For the
so there would be, they would go through a full licensing. So are you saying, do they automatically get accredited through that national association? I don't believe so, but I bet there are people on the call who can tell you that better than I can. I think that would be something they would have to seek out separately, but that continued certification would function as would qualify them for automatic relicensure under state law.
Okay, but if they didn't pursue that, if they didn't have that accreditation, they would have to go through the full licensing process again?
Right.
Okay,
right.
Thank you.
Right. I mean, it would just like for other types of facilities that go through renewal, licensure renewal, they wouldn't have that separate deemed certification option.
Okay.
For deemed licensure through certification. Yes.
Senator Hardy. Is that good for you, Senator Hooker? You all set? Okay.
Sorry, one other one.
Yeah.
The inspections as deemed necessary. How is that defined? I mean, there are not scheduled inspections or annual inspections or.
This is standard language that we have for hospitals and ambulatory surgical centers as well. So the health department could probably tell you how they do that. I believe they use some combination of both planned inspections and non-planned, sort of surprise ones so that they can see what's going on. The same things also happen in, I believe, in long-term care facilities. There is, I think, particular interest in seeing what is going on in facilities when they have not prepared for a visit.
Okay, thank you.
Senator Hardy.
Thanks. Jen, on the section on records, I think it's 2350. Is this referring to the sort of overall records of the center, not individual patient records?
Just get there.
It's
So this is all about information that is received by the Department of Health through filed reports, inspections, or as otherwise authorized by law. So to the extent they had a patient record for some reason, it would fall under this confidentiality and other confidentiality provisions. But this is really more about information that has been provided either by the facility or by others to the department.
okay. So this is, so the individual patient charts and things like that would fall under HIPAA like any other.
Right.
Okay.
Right.
Thanks.
Any other questions for Jen? Okay. So here's, I'm going to ask Lori Foster to testify first, and then Michelle Wade, and then we'll move on from there. So Lori, thank you for being here.
Good morning, and thank you, senators, for taking my testimony in support of Senate Bill 204. My name is Lori Foster. I've been a midwife for over 40 years and a resident of Vermont since 1981. I'm presently the Vice President and Legislative Liaison for the Vermont affiliate of the American College of Nurse Midwives. I'm the former president of the philanthropic organization, the Foundation for the Advancement of Midwifery. I've practiced in freestanding birth centers, community hospitals, tertiary care centers, and I also attended home births in a private practice for 25 years. Prior to becoming a nurse midwife, I was a certified professional midwife. I have served on the New Hampshire Midwifery Advisory Board, and I was part of the effort to license CPMs in Vermont. So you will be hearing from other witnesses about the need for freestanding birth centers and the advantages they offer families during maternity care. So I'm not going to focus on that because I don't want our testimony to be repetitive. What I'm going to focus on primarily is the economic impact of freestanding birth centers. And I also will address how birth centers enhance equity for birthing families. It's important to note, It's important to note that the freestanding birth centers achieve the triple aim of improving health care. Birth center care enhances patient satisfaction and quality of care through an individualized high-touch model. Birth center care improves the health of populations through lowering unnecessary interventions and supporting healthy pregnancy and birth for low-risk pregnant people. And birth center care reduces the per capita cost of maternity care. The AABC, which is the American Association of Birth Centers, estimates that Medicaid saves $19 million for every 10,000 women who give birth in a freestanding birth center. The CMS Strong Start program studied the economic impact of birth centers and found that costs were lowered by more than $2,000 over the first year for each mother-infant pair. These reductions were achieved by fewer infant emergency room visits, fewer hospitalizations, lower low birth weight rates, lower preterm birth rates, more successful VBACs, which is vaginal birth after cesarean, and lower C-section rates. So I call your attention to the fact that care at a birth center has as much of a positive impact on infants as it does on mothers. In communications prior to this hearing with legislators and officials, a concern has been raised that opening a birth center in a rural area might have a deleterious effect on existing in-hospital service. While it might be true that a small number of women from the community who would otherwise birth within the hospital may choose a birthing center, it is also true that birthing centers attract clients from other areas and also those who may have chosen to birth at home. While what a birth center brings to local hospitals is the ancillary services such as lab work, ultrasounds, maternal fetal medicine and OB consults, and ultimately a number of transfers. All of these services are likely to be more lucrative than providing global OB services, which do not actually tend to be moneymakers for hospitals. We have found no evidence that birthing centers have caused the closing of a hospital service. We had hoped that you would hear directly from certified professional midwife, Mary Lawler. Mary is a Vermont CPM who worked hard in the early 2000s to create a pathway for birth centers in Vermont. She was unsuccessful, and so she ultimately opened a birth center in Keene, New Hampshire. Just as an aside, it's interesting to note that out of the 5 freestanding birth centers in New Hampshire, 2 are owned and operated by Vermont midwives. Mary is also the founder, past president, and just recently retired executive director of National Association of Certified Professional Midwives. In those roles, she has provided policy support to states for regulating midwives and birthing centers, and has also worked with the US Congress and federal agencies to increase access to midwives and birthing centers. Unfortunately, she was unable to attend the hearing, but in her written testimony, she states, and I'm going to quote her, "Given all the proven benefits of birth centers and a growing demand from childbearing people for community-based perinatal services, it's more than time for Vermont, one of only 10 states that do not regulate birth centers, to join the 80% of states that do. Any state in the process of licensing birth centers will have concerns and fears about the impact. In my work around the country, as well as in New Hampshire, I am not aware of any hospital that closed because a birthing center opened in the community. Rather, communities become positively known for offering a full range of birth services desired by people." End of quote. I believe you'll hear a similar testimony from Dr. Timothy Fisher, who has extensive experience with birth centers around New England and the country, and who is an expert in the area of collaboration between hospitals and community-based maternity services. Another concern that has been raised, and which Senator Lyons requested we address, is whether there is a rationale for the certificate of need. The proposed statute explicitly states that it would not be required. The AABC, that's the American Association of Birth Centers, emphasizes that cons have a negative impact on birth centers. First, cons create barriers to birth centers without enhancing safety or improving quality of care. Second, out of the 40 states that regulate birth centers, only 12 require CONs, and those states have either no birth centers or in some cases just one. This is a dramatic difference compared to the states that do not require CONs. Third, birth centers provide services not provided by hospitals. They almost always have fewer than 5 beds and do not provide surgical birth or regional or general anesthesia. So they are not an equivalent service. To be clear, they do not duplicate hospital level care. The principal purpose of the CON, as I understand it, is to prevent duplication of services within a local or regional area and to prevent using unnecessary healthcare dollars as a result. It's very important to understand that birthing center services are not the equivalent to hospital-based services, and that even when midwifery care is offered in the hospital. It's also clear that birth centers save healthcare dollars while improving outcomes and patient satisfaction. In a memo from the National Conference of State Legislators to Representative Lucy Rogers, it was noted that several states have repealed CON laws over time, and New Hampshire is one of those. Another consideration, and this is the last point I'll make about the CON, is if the concerned parties view the CON as a way to control where a birth center is opened, we can guess that a more rural area would be more likely to run into barriers. If indeed that's the case, then if we include a CON, we may be setting up a situation where citizens of Chittenden County are likely to have a choice that family in more rural Vermont are denied. So the purpose of the statute is to create a pathway for Vermonters to have access to high quality care delivered in birthing centers, then requiring a CON would work against that goal without creating benefits. Another asset that I would like to address about birthing center care is the enhancement of health equity. Many LGBTQ and BIPOC people are afraid to birth in the hospital due to past trauma and mistreatment. The small setting and the continuity of care provided by birth center providers creates a safe space for vulnerable people. I worked closely with a birthing center service in Florida during my time with the Foundation for the Advancement of Midwifery, which is a national group. This center outside of Orlando served a primarily BIPOC population who had a very high rate of preterm birth. The model was an open door clinic, regardless of ability to pay. A dramatic reduction in preterm birth was achieved. In Vermont, we have pockets of new Americans who may be very wary of going into the hospital to give birth. Their traditions involve community care by midwives. Many of these families live in homes that are crowded and small, unsuited for home birth. Fear and stress are known to have a negative effect on labor and birth and also on the fetus. Thus, this is a part of our community who would be well served by birthing centers. In closing, I want to point out that the American College of Obstetricians and Gynecologists, along with the Society of Maternal Fetal Medicine, have a joint care consensus paper which advocates for birth centers as an appropriate and integral part of our national maternity care system. We know this is a service that Vermont families desire. We know it is safe and will improve outcomes for mothers and babies. We know it saves Vermont healthcare dollars. Finally, it's a reproductive choice pregnant people in Vermont deserve to have. I encourage you to pass S204 as it stands, and I thank you very much for your time.
Thank you very much, Lori. And given the time that we have and the number of folks who wish to testify on the bill, I'm going to suggest that we not ask questions unless it is a very succinct question of clarification. Senator Terenzini.
Senator Lyons, can you hear me okay?
Yes.
Okay. Just a real quick question to Ms. Foster. You probably said it, but if someone's giving birth at one of these centers and it's determined halfway through that they need a C-section, does the facility provide that service, or at that time they would have to be taken by ambulance, say, to a hospital?
Right. Yes, that would be a transfer situation. That's correct. And
if I may ask a follow-up question, does that pose any type of additional health risks that at that point the decision's made and then they'd have to be transported from one facility to another? Is there any danger in that?
well, I mean, the reason that there are rules and regs that clarify when those transfers happen, if they happen in a timely manner, then it generally does not. And the outcomes, you'll hear testimony from other folks about the outcome data, but we have a lot of data and the evidence is that it's a very safe option, even given that there is going to be a percentage of people that ultimately birth in the hospital. And that's a normal part of the birthing center function, and the families know that up front, that there could be circumstances where there would be a need to move from the birthing center to the hospital.
Thank you.
Yeah.
Okay, Senator Hooker.
Just a quick question. Ms. Foster, do you have your testimony for us? I don't see it on our website.
I will send it to you.
Thank you.
Yes, I'm sorry, I didn't send this one.
A lot of information. It was very, very thorough. And just point to Senator Terenzini's question, hospitals transfer patients from hospital to hospital as well.
No, we're going to, Senator, I think let's get into that discussion after we've heard from folks, because we have hospitals here, we have physicians here and so on. And I know that there are going to be questions like this going forward. They're good questions. Okay. So Michelle will be here later, but Alina is here and I hope, let me see if I can say it. Kumjian?
Kumjian. You did great.
Kumjian. Okay, great. Thank you for being here. And what I'm going to suggest to everyone who is testifying is that please try not to be redundant. I know that redundancy is sometimes good, but our time is quite limited and would like to hear some of the unique thoughts that you bring to us. So with that in mind, and we do have all of your written testimony on our webpage. I think most of you who are here, we have it. If we haven't, we will get it. So why don't you go right ahead?
Okay, thank you very much for inviting me today. I am speaking to offer my strong support for licensing freestanding birth centers as laid out in this bill. I've worked as an advanced practice nurse and nurse midwife for 9 years, most recently delivering babies at Cheshire Medical Center, Dartmouth Hitchcock, and Keene, New Hampshire. And when I moved back to Vermont and started practicing in the region, I was really surprised to learn that Vermont stands in a small minority of states that do not have a single freestanding birth center. New Hampshire, New York, Massachusetts, Maine, 39 other states have freestanding birth centers, so why wouldn't Vermont? After researching this question, I realized that the barriers to birth centers in Vermont are multifaceted. The legislation that we are discussing today is designed to end these barriers. So I'm going to focus in my testimony today on the overwhelming evidence that exists about the safety and excellent health outcomes brought about by birth center care. You can find in the supporting documents a handout from the Centers of Medicare and Medicaid Services outlining an initiative that spanned 4 years and compared 3 models of care, one of which was midwife-led birth centers. So in total, they had 45,000 Medicaid patients enrolled. Their stated goals were to find which model of care offered the most cost savings and improved outcomes. So as you can see, they found that freestanding birth centers saved over $2,000 for each mother-infant pair compared to matched Medicaid participants getting hospital-based care. Additionally, birth center participants experienced fewer infant emergency department visits and hospitalizations, and they had lower rates of preterm birth, low birth weight, and most importantly, they had fewer cesarean sections. The evidence that birth center care is cost-effective and provides for excellent outcomes with fewer interventions is copious. There was one 2017 study that compared low-risk women getting midwifery care in a hospital setting with matched low-risk women getting midwifery care in a birth center. And they found that the birth center patients still had a 37% less chance of having a cesarean birth. There was a review of 9 studies that found that starting your care in a birth center, even if you do end up transferring to a hospital, still conferred a lower cesarean risk. So for reference, in Vermont, 26.5% of low-risk births happen by cesarean section. In contrast, labors that start with birth center care end in cesarean only 6% of the time. Why would these birthing people have better outcomes outside of the hospital? Because in the hospital, we do an excellent job of taking care of medically fragile pregnancies, and in doing so, we overuse technology on physiologically normal pregnancies. The birth center model involves intensive relationship building, continuity of care, shared decision-making, and outstanding postpartum and breastfeeding support, leading to fewer postpartum mood disorders and healthier infants in their first year of life. If we're interested in reducing healthcare costs, improving the quality of care we provide, improving the health of Vermont families, improving access to care for Vermonters, then birth centers are definitely part of this answer. Given what we know about the excellent quality of care and cost savings conferred by birth centers, we do have a moral and fiscal obligation to offer this option to Vermont families. I would also like to read 2 short expert testimonies from witnesses who unfortunately could not be here today. Thank you for accepting my written testimony read by nurse midwife Alina Kumjan while I am traveling out of the country. My name is Dr. Heidi Reinhardt. I'm a board certified obstetrician gynecologist practicing at Cheshire Medical Center, Dartmouth Hitchcock, and Keene. I serve on the New Hampshire Midwifery Council and previously served on the Licensed Midwives Advisory Board in the state of New Mexico, meaning that I have been involved in the oversight of midwives who practice in birth centers in both states. I was affiliated with a freestanding birth center for 6 years and have attended births in that setting. I'm intimately aware of the differences in physical plant and practice patterns between a hospital labor and delivery unit and a freestanding birth center. I've worked with birth center midwives since 1988, providing consultation and hospital care for those clients who need them. I chose a freestanding birth center for the birth of my daughter, Juliana. I endorse passage of Senate Bill 204 to enable licensure of freestanding birth centers in Vermont. Freestanding birth centers in Vermont will expand citizens' birth options for family. Benefits of birth centers for Vermonters include low-tech, high-touch childbirth services with significantly lower costs, higher satisfaction, and many fewer obstetrical interventions, including fewer C-sections when compared to hospital birth. And this is achieved with equivalent health outcomes for babies and better health outcomes for pregnant people. There is a bit more to this testimony, but as you said, you have it written down. I want to not take up too much time, so I'm going to
No, thank
One
you.
more, read one more quick letter if that's all right.
Please do.
Thank you. Dear committee members, I'm sorry that my clinical responsibilities prevent me from attending this hearing today. My name is Dr. Autumn Versace. I have been a midwife for 14 years. For 7 of those years, I owned and operated New Hampshire's largest freestanding birth center. I can speak to how this legislation serves the public interest as a midwife, as a mother who received my own care in this model, and as the chief of hospital-based obstetric practices, and as a healthcare quality improvement scholar. The safety, value, and quality of birth center care is well established. An analysis of over 6,000 deliveries enrolled in the Center for Medicare and Medicaid Services Strong Start Initiative concluded that birth center care improves health, patient experience, and value. The model demonstrates the potential to decrease racial disparity and improve population health. Reduction of regulatory barriers and implementation of sustainable reimbursement are warranted to move the model to scale for Medicaid beneficiaries nationwide. Concern has been raised that freestanding birth centers would undermine the stability of rural hospital units. I have not found this to be the case. As the section chief of obstetrics at Cheshire Medical Center in Keene, New Hampshire, a community hospital with a freestanding birth center 7 miles down the road, I found that 5% of our slowly increasing annual delivery volume came from well-managed intrapartum transfers to us from the birth center. The birth center practice also generated ancillary hospital revenue through patient consultations, ultrasounds, and lab services. In fact, freestanding birth centers enhance regional obstetric care systems in 3 ways. 1, they increase and diversify care delivery location, which affords patients better choice and systems better flexibility, for example, in pandemic response planning. 2, they may help to decompress our specialty and subspecialty centers, keeping low-risk patients in their home communities and affording better regional capacity for medically complicated patients to get the care that they need. And 3, they improve quality and they save money. As we had mentioned earlier, cost savings of approximately $2,000 per delivery. Freestanding birth centers are part of the obstetric care system in all surrounding states, New York, New Hampshire, and Massachusetts. With this legislation, you will remove regulatory barriers and ensure reimbursement, finally granting Vermont families the choice to move their care into a model of proven safety, value, and quality. The obstetric healthcare system in Vermont will certainly benefit through better quality, enhanced capacity, and cost savings. Thank you for your consideration, Dr. Autumn Versace.
All right, thank you. And you've read 3 other testimonies, or at least letters, in addition to your own testimony. And I'm not sure that we have all of that. So if you could please send it to Aaron if you haven't already. That would be
Yes, I've sent it. So I read my own,
yeah,
and 2 others.
I get it. Okay. So I'm just going to say to folks, we only have time for the people who are here. But we really appreciate having the additional information, but so do send it along to us. But if we want to get through what we have today, we won't be able to do it. But thank you, Alina. It's very, very helpful. Greatly appreciated. Senator Terenzini, a quick question of clarification.
I think it is, and I apologize. I'm going to ask probably a lot of questions this morning. This concept is quite foreign to me, and it's intriguing.
Uh-oh. I think you froze, Senator. Senator, save your question, and we're going to move along.
Can you hear me? Can you hear me, Ginny?
Now I can. Yep.
Oh, I was paused because I heard someone else say something.
Oh,
So
go ahead.
That being said, my wife we had 4 kids in the hospital, and so I understand about the C-section question I just asked, but what about services like epidural or other things that women might choose to have? Are those services that are provided at these places?
Can I suggest? Well, that's a good question. It's a yes or no for Alina. Are those services provided? And we're going to get to some folks who work within the hospital setting. So
yes, and I do work within the hospital setting.
Yeah. Okay.
So no, the service of an epidural, service of a C-section, not provided in a birth center, and that is part of why it is not duplication of care.
Thank you.
Okay. Yeah, there are a lot of these questions. So We have Dr. Timothy Fisher here. Here's the order. I've got folks in right now. Timothy Fisher, Kat McGraw, Jessa Barnard, Laura Pelosi, Robin Lunge. And then I have a couple of other folks who I don't see here as yet. But Michelle Wade, I'm going to try to put you in between some folks because I know you just showed up. So thank you. So Dr. Fisher, thank you for being here.
Good morning, Senator Lyons. Thank you so much. Senator Hardy, members of the committee, I have submitted my written testimony to your aid, so you should be receiving that. I sincerely appreciate the opportunity to offer my testimony today in strong support of Senate Bill 204, an act relating to licensing freestanding birth centers. By way of background, I'm a board-certified OBGYN physician at Dartmouth Hitchcock Medical Center. I'm an assistant professor of obstetrics and gynecology at the Geisel School of Medicine. In addition, I serve as the medical director of the Northern New England Perinatal Quality Improvement Network, which is a voluntary consortium of over 50 healthcare organizations and professional associations.
Dr. Fisher, is there a way that we could have your sound improved? There's a little echo coming through and it makes it difficult for some folks.
I'm a little too far away from my.
That's better. Whoop.
Sorry.
Okay, we can hear you now. We can't see you, but we can hear you. Yes.
Okay, great. I can try to adjust that camera. I apologize. There we go. Okay. How's that?
Great.
Okay. To continue, I'm the medical director of an organization called NEPWIN, which is a consortium of over 50 healthcare organizations and professional societies that includes all of the birthing facilities in Vermont and New Hampshire. For 10 years, I was the chair of OBGYN and surgical services at Cheshire Medical Center in Keene, New Hampshire, where I worked closely with midwives from the Monadnock Birth Center in Swansea and the Birth Cottage in Milford, New Hampshire. More recently, I've been involved in an advisory capacity to the midwives and owners of the Gentle Landings Birth Center, owned as one of our previous witnesses mentioned by a licensed Vermont midwife here in Hanover, New Hampshire. Across these years, I've worked closely with midwives and their clients receiving full scope maternity care at birth centers, developed a model for interdisciplinary quality improvement conferences between sites. I participated in the development of guidelines for community-based midwives and hospital-based care providers to optimize the effectiveness, safety, and efficiency of consultation, referral, and transfers from the home or birth center environment to the hospital. Finally, I've contributed as co-author on several peer-reviewed publications related to collaboration between community-based midwives and hospital-based obstetricians. For me, the sum total of these professional experiences has reinforced the vital and necessary role that birth centers play in the continuum of care for pregnant and postpartum people across the region. Here in New Hampshire, we've seen over a third of our hospital-based labor and delivery units close. So that dynamic, as well as the COVID-19 pandemic, have really only served to reinforce the urgent need for the development of alternative sites for ambulatory maternity care, labor and delivery of risk-appropriate patients. Those of us as highly trained specialists and subspecialists who work in hospital-based labor and delivery units are caring for an increasingly complex patient population who require a level of resources that are simply not necessary for the vast majority of healthy people experiencing the physiologic processes of pregnancy, labor, and delivery. Placing these patients in a high acuity and resource-intensive clinical environment exposes them to unnecessary interventions that we know result in poorer outcomes, including higher rates of cesarean delivery and perineal trauma, to name a few. And far from being competitors, birth centers and hospital-based units have the opportunity to improve health outcomes as collaborative complementary models and sites of care. I'm not going to repeat policy statements and results of research cited by previous witnesses, but suffice it to say, accredited birth centers are endorsed by medical professional organizations and federal agencies as safe and high-quality components of a robust maternity care system. From the perspective of the triple aim, birth centers are a no-brainer: better outcomes and higher patient satisfaction at a lower cost of care. As a public health intervention and a means of responsible stewardship for our precious healthcare resources, I strongly encourage you to approve this piece of legislation with all of its provisions to clear a path for the development of freestanding birth centers in Vermont, including establishing a licensing structure, requiring coverage for services under health insurance plans, and without being subject to an onerous certificate of need review. Thank you for the opportunity to participate this morning. I'd be happy to take any questions.
Thank you very much. That was very helpful. So unless there's a question of clarification, I think we're just going to keep moving along, and then we will probably have questions later on that everyone on the screen will be able to help answer. Okay, so I'm going to move next to Dr. Kat McGraw, and then Michelle Wade, and then Jessa. So that's I just inserted Michelle, you into the testimony. I knew that you were coming in a little bit later. So, Dr. McGraw.
Thank you. So thank you for allowing me to testify about the licensing of freestanding birthing centers. And I want to comment specifically on the question of whether they should be regulated by the certificate of need process. I am the chief medical officer at Brattleboro Memorial Hospital. I'm a hospitalist. Practicing hospitalist. I'm also on the Vermont Association of Hospitals and Health Systems Board of Directors, and I chair the Chief Medical Officer Committee, which includes all of the chief medical officers from across the state. So I'd like to just start by describing the state of OB right now in Vermont, and then look at what having or not having a certificate of need process would do to that reality. Nationally, births are trending down, and we see this dramatically in Vermont, which per CDC statistics has lowest birth rate in the nation. Nationally, less than half of all rural counties no longer have OB services because of the expense of providing such services. In Vermont, providing OB is a labor of love, poorly compensated, and frankly, high risk. Most of the births are Medicaid funded, and hospitals providing birthing services do so at quite a loss. Brattleboro Memorial Hospital, or BMH, alone loses $4 million a year on its birthing services, roughly half of that from the OB offices and half on the hospital side. Between 2012 and 2021, the total number of births at BMH dropped 31%. Springfield Hospital also had a declining number of births and an insurmountable loss of money associated with it. In 2019, they elected to close their birthing services. BMH stepped in to assist that community by providing prenatal services on-site in Springfield and deliveries at BMH. Our total decline in births that I mentioned previously includes the addition of these patients. Currently, OB services in Vermont are very at risk. The finances do not support them. The communities want and need them. Most of the services, frankly, are Medicaid, and yet the risk of not having services within a community locally can be very large. Maternal and fetal mortality is not a theoretical risk. Advanced practices and technology have helped reduce the risk, but it is with the careful attention of highly skilled personnel and attendant surgical services that this risk is aptly managed. The skill level of these personnel cannot be overlooked. In fact, during COVID, as we had to redeploy various staff to other areas within our hospital to provide care and plug holes in our staffing, we did not deploy other staff into our birthing center. Why? Because as difficult as it is to take a nurse from one setting and move them to another to help cover needed absences, it is simply not possible in OB. The skill set is specific and learned over time, and anything that jeopardizes that nursing workforce also jeopardizes the safety of our deliveries. So what does it take to run a birthing center? A hospital birthing center. It is one of those services that has to be ready 24/7 to deliver babies. That means having staff on site, even when there are no laboring patients. That means having an anesthesia team at the ready at all times. It is also a service that needs volume to be able to remain skilled. That's part of why we picked up the Springfield services. Low birth numbers are a problem in Vermont. Everyone has to work hard to keep up their skills since we don't have large volume. And volume is key to not only seeing the normal presentations, but also successfully learning and practicing the less frequent presentations and being able to readily identify the potentially dangerous situations. And make no mistake, those are not uncommon in births and endanger not one, but two patients, both mother and baby. Right now, our community hospitals manage the routine deliveries, the known low-risk deliveries, and the unknown high-risk deliveries. We also take care of emergency birth situations that arise from home births that encounter problems. Our doctors have to step in to pick up the pieces of home births with difficult. These patients arrive in the midst of delivery without provider relationships, with a patient who has intentionally not chosen a hospital for birth and a situation that almost always involves risk and surgery. These are the patients for whom the true commitment of the doctor to the well-being of a patient, no matter the situation, is most evident. A freestanding birthing center would depend on a nearby hospital to provide C-section services for patients. Nationally, the number of patients needing C-sections from a freestanding birthing center stands at around 6%, a low number, but a real one nevertheless. These are patients for whom delivery can be an in-process on transfer with dramatic consequences if surgery is not readily available. The need for speed is why we have an operating room actually in our birthing center. We have learned that the time it takes to get a patient into elevators and into an OR elsewhere in the hospital can be wasted minutes and make the difference between a safe delivery of a healthy child and a much more heartbreaking, complicated outcome. A freestanding birthing center depends on the ready availability of a hospital to provide this. Any freestanding birthing center needs the presence of the skilled hospital-based program as a partner for patient safety. So what would happen if we had a freestanding birthing center in communities for which there was not a true assessment of need? To start with, the volume of deliveries for the hospital would obviously go down. This would jeopardize the skill set at the hospital for delivering babies, but I would posit that it also jeopardizes the skill set of those in the freestanding birthing centers, since low numbers split into two parts become very low numbers for both entities. This means that hospitals and physicians would need to evaluate their ability to continue their safe skill set for the service. A natural outcome is the risk of closure of hospital-based birthing centers. This means more OB deserts. It also means far more risk for patients and their babies having to travel such distances. Further, a freestanding birthing center without evidence for its need for its presence would put hospitals in a much more fragile financial situation. The reality is that right now, hospitals are already very fragile. I'm sure you're aware of this from a number of angles, including the beleaguered workforce, the missing workforce, and the fragile state of finances, initially caused by COVID, but now existing as a new normal. A freestanding birthing center will obviously not be taking all comers. They cannot keep their doors open, working at substantial loss the way that hospitals do for these services. It means shifting the payer mix, taking the private insurance and private pay patients and leaving Medicaid patients for hospitals. Furthermore, routine hospital births subsidize complex births. This equation creates insufficient numbers on both sides, a much worse financial burden for the hospital, risking hospital sustainability. In addition, it risks creating situations where patient giving birth in an outpatient setting has nowhere to transfer for the emergency birth care. Make no mistake, a freestanding birthing center could provide an amazingly beautiful, safe birthing experience for some patients. There is no question about that. But the key is in the importance to have the need for that center evaluated in that community. That's the only way to ensure the safety as a result for all the patients. At a minimum, ensuring there's a need is the first step in providing care. That is, in fact, the whole purpose of a certificate of need is intended to ensure that there are no duplicative services, to provide some cost containment and provide for equity of access. A lack of this process endangers the safety of our patients as well as the financial stability of the hospitals, and in the event of resulting OB closure, creates longer drive times for routine hospital births and an untenable distance for emergency interventions. Please, please consider this full perspective as you consider the request to exempt freestanding birthing centers from the certificate of need part of the process. Thank you.
Thank you very much, Dr. McGraw. Very helpful. And if you would please send your testimony into Aaron so that we have it on the record, that would be very helpful.
Yes, can Aaron post the email address in the chat for me? Thank you.
Sure. Aaron, can you do that? I think he contacted you to testify, so you should have
I'll
that.
email you. That's fine.
Really? Okay, thanks, Aaron. All right, so let's move on to Michelle Wade, who is here. And Michelle, thank you for being here. And then after that, we'll talk with our next witnesses. I think I have Jessa Barnard, Laura Pelosi, Robin Lunge, and Michael Barber from at the end. And then we have a couple of, I don't see the other two people, so we'll just continue with that. So Michelle, thank you for being here.
Thank you for inviting me. For the record, Michelle Wade, I'm a nurse practitioner and the president of the Vermont Nurse Practitioners Association. I actually had submitted a letter to this committee with a personal stake in this, and I want to share that with this committee. I apologize if this stuff has been shared previously. I did miss the first couple people due to a prior commitment, but part of my stake in this personally, and then I'll get professional, is that there's currently no certified nurse midwifery available in Rutland County. It is a desert area. My adult children have had to travel to both Porter for one, and now traveling to Gifford and Randolph for their second child. This is potentially a safety issue for these young ladies to be traveling over 60 minutes for CNM appointments monthly, and especially once they're in labor, and the timing for the safety of that trip while they're in labor. If CNM care were available in our area, my children wouldn't be traveling. CNMs are an advanced practice registered nurse, and that's part of the reason why I'm here today. They provide primary care to women of childbearing age and beyond with comprehensive range of services. These services also include primary care, gynecology, and family planning services, preconception, care during pregnancy, childbirth, and in the immediate postpartum period. These CNMs establish relationships with these patients while they're utilizing the freestanding birth centers and maintain relationships with these patients and provide some of the primary care that we are missing. I did hear much of what the next section of my testimony was, so I will not repeat it, and I have submitted my testimony to you specific to data, so I see no reason to repeat that. What I would like to say is, how can we improve access to care across the state? VMPA feels that freestanding birth centers would improve access to CNM care throughout Vermont by adding a CNM option for care to the desert care areas and allowing access to these APRNs. This is a natural process that birthing moms go through. If they don't want to be in a hospital setting, they're more likely to do it in a home birth setting, which is potentially more dangerous than in a freestanding birth center, which has an established relationship with an area facility. I also think that I heard Dr. Fisher state that he has a relationship with a couple centers, so that speaks to that. What are the social aspects of this? Social aspects include that the patient will be able to get their care in a non-hospital setting as long as they are a low-risk pregnancy. The care allows the families to be in a low-stress environment for this monumental time in their lives. We have families in Vermont that are doing this unsafe because they don't have access to a safe version of this care. So my summary is, this bill is as much about autonomy and women's rights as it is about providing a proven, safe, and very cost-effective healthcare option that is currently not offered in Vermont. The remainder of my testimony is duplicative, so for the sake of time and the long list of people that are here, I will yield to anyone else, but I will stay for questions at the end.
Thank you. Thank you for that. And there will be questions at the end, and then how your experience and your work fits into those answers will be very welcome. Thank you very much. We're going to move along to, our time is getting better and better as we go forward. You're all super witnesses with great testimony. And I know that there are a number of questions that we will have, but we'll keep moving along because some of this gets complex. Jessa Barnard is here from the Vermont Medical Society. Jessa, welcome.
Thank you very much. Thank you for having me this morning. I am Jessa Barnard, the Executive Director of the Vermont Medical Society, representing our physician and physician assistant members from across the state. And I'm here this morning to testify on S204 after reaching out to a number of our GYN members across over the fall to get feedback on the bill. Unfortunately, they were not available due to clinical conflicts this morning, but I'll do my best to summarize the feedback I heard from them. We all agree that women in Vermont should have choices about where they give birth, and we also need critical 24/7 access to emergency and high-risk services when things don't go according to plan. So while overall VMS does not oppose the licensing of freestanding birth centers or S204, we do think it is important that birth centers go through the certificate of need process to ensure that they don't endanger access to hospital, labor, and delivery services that we all depend on for safe outcomes. We have significant concern regarding the impact that new birthing facilities could have on staffing and capacity at existing birth facilities. And I know you already heard some of this from Dr. McGraw, so I will also do my best not to repeat what you heard from her this morning. But existing facilities in Vermont and neighboring states and rural states across the country are struggling to keep birth centers, birth facilities and hospitals open. You heard this morning about how Springfield Hospital closed its labor and delivery unit in 2019, requiring many women to travel up to an hour for services. There's been recent coverage regarding the number of New Hampshire hospitals closing their labor and delivery units, largely due to financial pressures and declining birth rates. And there's been national coverage, especially about the impact of high Medicaid rates and low birth rates in rural states and how rural states are struggling to keep obstetrics care available 24/7. Another facility in a small state with few births could potentially have negative impacts on existing facilities remaining open, especially that high-level OB care and the 24/7 emergency and transfer capacity that you heard Dr. McGraw describe so clearly. And these are the services that a freestanding birth center would depend on if a pregnant patient needs to be transferred due to complications that arise during prenatal care or delivery. And we don't think there are necessarily easy or quick answers today to that question of how many birth centers there should be in Vermont, where they should be located, or how they could impact hospital birth facilities remaining open. Just this morning, you've heard both sides of that argument. So instead, those are the exact type of issues that the certificate of need process is designed to wade through and answer and determine. As you already heard, the purpose of CON law in Vermont is to avoid duplication, contain costs, and at the same time, and this is from the statute about the purpose of CON law in Vermont, maintain and improve the quality of and access to healthcare services and promote rational allocation of healthcare resources in the state. So we think it is important that a CON process review these questions along with looking at Vermont's Health Act resource allocation plan and all of the ongoing conversations your committee is well aware of regarding hospital sustainability and equitable access to healthcare services. Maybe it is the case that it in fact would increase referrals or services done at hospitals, or maybe it's the case that it would draw patients away. And I don't think, again, that your committee would easily be able to answer those questions in a few hearings this session. If the committee does move forward with the licensure, we do agree with the section of the bill that asks the Department of Health to issue rules that address practice guidelines and procedures for transferring patients to a hospital. And then we also suggest if the committee's moving forward, that you hear from the Department of Health that oversees licensing for hospitals and other health centers for further information about what implementation could or might look like. And just to flag again, back on the CON piece, that ambulatory surgical centers also go through that process in Vermont, as you're probably aware. So we're not saying that that birth centers are necessarily providing the exact same services as hospitals do, but they fall in the realm of the types of services that do go through CON process in Vermont. So thank you for hearing from me this morning. And I will submit my testimony in writing as well. Thank you.
Oh, good. I was going to ask you for that. Very much appreciated. And you've identified some areas that we have been working on. So this is important. So we'll keep moving along unless there's a question of clarification for Jessa. I do have one question. Are you suggesting that the birthing centers go through the same process or similar process as the freestanding surgical centers?
Well, I just to clarify that the ambulatory surgical centers, freestanding surgical centers are in Vermont subject to CON law.
Right, it's a
So,
modified
yes.
process. I just
Sure.
want to know whether you're talking about the full hospital process or something different.
That's a good question. That may be more of a question for the Green Mountain Care Board experts
Okay.
on CON. I know they go through a different licensing process in Vermont. I'm not sure if I'm actually not aware if it's a modified CON process. That's a good question. I don't have an
We'll
answer.
find out.
Yeah, great.
Okay, thank you. All right. Let's keep going. And we have Laura Pelosi is here representing the Vermont VAS hospitals. Devin Green got stuck in an airport, apparently. Doesn't sound like a good time.
You did. Thank you, Madam Chair.
Go ahead, please.
Thank you for accommodating our quick switch. I'm Laura Pelosi, and I represent the Vermont Association of Hospitals and Health Systems. I won't do nearly the stellar job that Devin Green would do for you today, but frankly, Dr. McGraw and Jessa Barnard have saved me from myself. And so I won't duplicate any testimony except to say that VAS strongly supports adding a certificate of need requirement to S204 for all of the reasons that you've heard in terms of ensuring patient safety and the need to ensure that hospital birthing units remain viable and available for the Vermonters who need to receive care from those hospitals and from the clinicians that work in those birthing units in the hospital. So I'll leave the remainder so that we don't duplicate. I'm happy to try to answer any questions. And if I can't answer questions, I'll certainly take it back and bring answers back to you. Thank you.
Okay. Thank you. And do we have this in writing?
We'll get you something.
Yeah, you're going to get it to us. Okay. That would be helpful. We have two people here from the Green Mountain Care Board. Robin, you're here, and Mr. Barber is also here. How do you want to proceed?
So I'll go ahead and start, and then I'll turn it over to Mike to go through a very brief overview of CON. So first we'll introduce ourselves. I'm Robin Lunge. I'm a member of the Green Mountain Care Board, and I'm here with Michael Barber, who is our general counsel. The board doesn't have a position on the bill per se. What we were hoping to do today is provide you some background on certificate of need, and specifically related to section 3 of the bill, which exempts freestanding birth centers from the certificate of need process. So what we were going to do is start with a very brief overview of the key facts related to CON and the process, just to give you the basics. If you'd like us to do a deeper dive at some point, we're happy to come back and delve more deeply into the details. So I'm going to turn it over to Mike, and he's going to share his screen. We submitted a one-pager to you this morning, which you should have available. And Mike, if you want me to share my screen, let me know.
I think screen sharing was disabled, but I can just run through the facts. Oh, okay. Is that showing up for other folks?
Yes.
Looks good. If you could maybe enlarge it a little more, that would be magnified. That's better. Thank you. Sure.
So again, Michael Barber, General Counsel for the Green Mountain Care Board. We did think it would be helpful to just do a quick review of what the CON process entails, and starting out with some statistics in terms of the volume of applications we receive. We typically end up reviewing approximately 6 CON applications per year on average over the past few years. The board also has a number of projects each year where it's determined that a CON is not required, and that varies quite a bit year to year. So between 2018 and 2021, it's been as low as 5 per year and as many as 15 per year. Most applications are reviewed under an expedited review process. So between January 2019 and February 2022, the board granted 16 requests for expedited review, and denied 3 requests. To your question, Madam Chair, there is not a separate process for different types of facilities, but it's based on kind of whether the project involves significant policy issues. So there's a standard there, but it's not tied to the, whether it's an ambulatory surgery center or whatnot. In terms of time it takes to review, so on average, it's taken the board a little under 50 days to close a CON application in the expedited review process, and a little over 60 days in the standard or non-expedited process. I'll skip over kind of what triggers CON review in the interest of time, and just skip to what that review looks like. So it starts with a letter of intent generally, which forms the basis for determining whether the CON is required. If a CON is required, the board typically has 90 days to review and close the application. Some applications are more complete than others. If the board has questions, which is often the case, the clock stops while the applicant is answering those questions. After the board closes an application, it has 120 days to decide whether to approve it in whole or in part, to deny it, or to conditionally approve it. A hearing is held unless the application is being reviewed under those expedited procedures. If there are competing applicants or interested parties, the application comes out of the expedited review process and proceeds under the standard process, except that the competing applicant or the interested party can waive a hearing. So with that kind of general overview of the process, I'll turn it back over to Robin to.
Great, thank you, Mike. So I think as has already been touched on, so I certainly won't go into great detail about it. The certificate of need process in statute provides a different role than a licensure process. A licensure process is really looking at health and safety and specifics of a particular applicant in terms of meeting the health and safety standards that the Department of Health or the licensing agency has set. In the certificate of need process, we're taking a bigger look. We're looking at that application, but what is the role of that application in the larger healthcare system for that region? So there is, the standard does include a determination of need, and that determination of need looks at a number of different considerations, including impact on any healthcare facilities in that region, as well as the public interest in having that type of new healthcare project in the region. So it is meant to provide some protection against duplication of services, but also to do an assessment of the larger public interest around those sorts of healthcare systems or applications. With that, I think I will wrap up, because I think if you want us to do more detail or more information about CON, we're happy to do that, but it might, in your interest of time, make sense to have that be driven by your questions.
Let's see what questions folks have about this. I think the question about some review for geographic distribution in the state is something that, can you talk a little bit about how Green Mountain Care Board might look at geographic distribution of access to facilities? Because we hear about that all the time, and can you
Sure.
talk more about that?
Absolutely. So in the certificate of need application, it is in the certificate of need process, it is application driven. So we would not, as a board, take a look across the state and say, we think we should have, in this example, freestanding birth centers or some new service in these 5 areas. It's not that type of process. The process would be driven by an applicant filing saying, I would like to open a freestanding birth center in Rutland County, Newport, wherever. And then we would rely on the applicant to provide their assessment of need. And then typically what happens in our process is that if the application is incomplete or doesn't address all of the statutory criteria, which quite frankly is extremely common, our staff member will work with the applicant through a question and answer process to pull out the relevant facts and information so that the board can assess the application versus the criteria. So in terms of geographic distribution, the particular location would be driven by the application. We would take a look at that region. What other services are offered in that region? Do we think that there will be an impact on any other healthcare facility that's offering those services? So just to make it concrete in this example, if we received an application for a freestanding birth center, we would look at, is there a hospital in that region offering these services? Is there a duplication of services? What is the volume of births in that region? Are there concerns around low numbers? And those sorts of considerations. But it is an application by application process, and because it is quasi-judicial. So we are looking at the information provided by the applicant, but then trying to flesh out those applications through a Q&A process.
Okay, but then I'm going to go to Senator Cummings and then Senator Hardy very quickly to put a pin on the capital expenditure. So this would be if the facility reaches a level of capital costs of 1.5 therapeutic.
You can see that and maybe Mike wants to go over those. There are a number of different areas that could trigger jurisdictions. Capital costs is one of them. Mm-hmm. Mike, do you want to just touch on that?
Yeah. The one that is probably most likely applicable would be the offering of a new healthcare service with an annual operating expense of over $500,000 for either the next two budgeted fiscal years. All these jurisdictional amounts are something that the board can from time to time adjust, and the board is currently going to take that up, I think. But yeah, it's currently $500,000, and that's the most likely thing that would bring in a freestanding birth center, I believe.
Okay, thank you. Senator Cummings.
I'm muted. I've been concerned, and I think I've told all the emails that have come to me that I've been through the gamut where my husband sat in the waiting room where he could go home, and there was like an old gym, communal labor room, to my husband was there with me. So I have been through all the experiences except freestanding. I think they're great. But my concern has been we have some very fragile hospitals. They're starting to shut down their birthing centers. And I want to make sure, if you're up in the kingdom and there are no east-west roads in the middle of this Friday and you are in trouble, I want to make sure that there is a hospital with an OBGYN staff capable of answering that, because I don't think you can be medevaced out in the middle of a snowstorm. So does Green Mountain Care monitor that? Who's monitoring that balance between allowing consumer choice, not having not putting women in medical facilities if they don't need it, and at the same time in these very small hospitals helping them cover the cost of keeping that staff on 24/7. I've never had a child come in the middle of the afternoon.
So
snowstorms were big.
Thank you, Senator Cummings. So as part of the certificate of need process, the board would look at potential impacts on any other facilities offering those services. So in the example that you gave, we would look at what services the hospital is providing. If they do have a birth center, we would try to assess based on the information that we have available, whether or not the new facility would have an impact and the magnitude of that impact. Because as was noted earlier, there would be expected to be some impact, but is that a small impact? Is it a large impact? That's the type of detail that the certificate of need process tries to assess to determine whether or not there's a need for a particular project in a particular area. But that is a case-by-case determination.
Okay. All set, Senator Cummings?
Yeah, I'm just thinking, as we look at these specialty services, we might need a statewide plan, rather than trying to keep staff. This isn't the first time we're going to deal with something like this.
No, it's not. And in fact, we have dealt with it previously. The HRAP, the Health Resource Allocation Plan, was a big part of the discussion on our home health agencies, if you recall, a few years ago. And we've had continuing conversations with a variety of different healthcare organizations types. So, and the Green Mountain Care Board is theoretically looking at HRAP as it does its work. Is that accurate, Robin?
Yes, absolutely. And as you may recall, we did do some changes to the HRAP statute, the Health Resource Allocation Plan statute a few years ago, with the goal of trying to revitalize that. And we have been working our way through different sectors to make sure that we want it to be more dynamic. And so we've been working our way through the different subject matter areas. Quite frankly, the pandemic, like many things, did create a slowdown in that process, because part of what we need to do is collect supply side information from facilities. And it didn't seem like the time with the pandemic to be doing that type of data collection. So we did put some parts of the HRAP on hold because of that. But certainly the other area that your conversation raises for me is, as you know, and we will discuss tomorrow morning, the board does have a request for some dollars to support a community process where we look at essential services in communities.
Yeah.
And so certainly, I think that process could raise some of these same issues.
Senator Hardy has a question.
Thank you, Madam Chair. I'm concerned, Robin, I'm wondering if the CON process takes into consideration things about access to services for patients in a specific way. And so, for example, when I had my babies at home with a midwife because my area at the time had no midwifery service, similar to what Ms. Wade was talking about with Rutland County. And I wanted to have my babies with a midwife. And the only option for me without driving really far in the winter was to have a home birth. And it was low risk, and I had an amazing experience. I would not trade it for anything. But I am concerned about, I heard from Ms. Wade that there's no midwifery services in Rutland County. There was someone else, I think Ms. Foster gave the example of midwifery services for new Americans. And I'm wondering, does the certificate of need take into account those things, like for a specific, the fact that there aren't midwives in Rutland County, or the fact that there may not be midwifery services for new Americans in Winooski or whatever? Or is it just looking at facilities? Do you know what I mean? Is it looking at subpopulations?
It depends on the application. So in this instance, you could see that theoretically and hypothetically, a freestanding birth center might, as part of their application, make a case that the need in this particular community is a lack of the types of services that you just outlined. So you could see, so I could see theoretically, and I'm trying to be careful here because we wouldn't want to prejudge any specific application, and certainly would need to determine any decisions based on a specific application, but at least theoretically, you could see an argument around need focused on those sorts of access issues for sure.
Okay, but it doesn't take, I've heard you say this, and I just want to confirm that it doesn't look at a statewide sort of need. So to say, well, there might be need in Rutland County, but not in Addison County or whatever, you're not doing that kind of planning.
Not in a certificate of need, because it is an application driven quasi-judicial case-by-case process. The type of planning that you're discussing would be more appropriate for something like the health resource allocation plan.
Yeah, because I want to be able to figure out a balance between these two things where we get these really critical healthcare services for people who want and need them, like I did, but don't over provide healthcare services in some areas, both at a cost to our hospitals and a cost to our residents, our people of Vermont. So balancing that need, and it doesn't sound like the certificate of need process quite does that. It does it on a micro version, but not a macro version. And so how do we ensure that we could do this on a more of a macro version? It's through the HRAB process.
Yes.
Do you have suggestions for how we might integrate that better into this?
Well, certainly when so the way HRAP has been working most recently is that we tackle different sectors either because it comes up in a regulatory process or because we're systematically trying to develop the revised HRAP. In this particular instance, so let me give an example from a case. So in a recent application for a newer type of facility in Vermont, the board had a staff analysis done of need for those services in the region as sort of tangential, as part of that certificate of need application, but because it had not yet been tackled in HRAP. So we would certainly do that if we were to receive an application to try and assess the need in that particular service area. But in terms of the HRAP, I think I'd want to go back and talk to our staff and think about how we could look at these types of services and bump it up the priority list. And you could certainly direct us that you wanted us to bump it up the HRAP priority list. But each sector, in order to develop that type of analysis, it's not an insignificant effort of both data collection for data that's not currently collected on the supply side, along with then an analysis on a statewide basis of need for that particular service. So I think when we were first talking about the HRAP, I underestimated kind of the intensity of that work, I would say. So I don't want to make it sound like it's something that we can do, in a week, for example. It would be likely a several month process where we would need to collect new data and then do an analysis, have one of our staff members from the data team do an analysis around this particular suite of services.
Mm-hmm.
So that certainly could be done. It would need some time.
Okay.
Okay, I do have a little, are you all set, Senator Hardy, at this point?
Yeah, I'm just mulling. Thank you.
Okay, keep mulling. So I have a couple of questions. One is with regard to how the HRAP, because we've been through this previously on other issues, and the use of any of the data available through the Department of Health on the health improvement plan, and knowing that is basic to driving some of these decisions. So is that information available? How are you going to be using that? And would that information accelerate the process for making this kind of determination for birth centers?
Absolutely. So we don't redo work if somebody else has done it. What we do when we're looking at a particular HRAP area is we will reach out if there's an existing state agency that's collecting data on that topic. We would certainly reach out to them. We would work with them. And if they've done the analysis, we would quite frankly simply link to it as part of HRAP. So what we, in the revisioned HRAP, what we've tried to do is really see it as a consolidation of different existing data sources where possible. So that's the first go-to. And if there's not a data source with the necessary data, then we would move to data collection. So we would not independently collect data if it's already collected by someone else.
Okay, and but understanding, my understanding is that it's written into statute that the health improvement plan is the basis for some of the decision-making at the board. I'll have to confirm that, but I think it is in Title 18 somewhere.
We do look at the state health improvement plan. It is not the type of data that I would say typically would fit nicely into a regulatory process.
It's so more goal setting, probably.
Yes.
Yeah.
Yes.
Okay. All right. That's helpful. And then the other question I have, and this is more, unless there are there other questions now for Robin and Michael on the CON process committee?
Just one
okay,
thing.
And then I want to come back because I have another question.
That's okay. Just Robin or Michael, if you could just send us more complete information on how the CON process works. Once you get the application, what does it look like and what are you doing with it?
Sure. And I think we're happy to do that. It will depend on the quality of the application, to be frank. So many of the applications that we receive are missing key information necessary to make a CON determination. And so how that process flows really depends on the quality of the initial application. So in some circumstances, there may be one set of questions. In other circumstances, there may be several set of questions. And it's not, quite frankly, it's not uncommon to have one part of the CON application conflict with the other. And then we have to, go back and forth with the applicant to figure out which facts are correct. Because it is, as a quasi-judicial process, we need to establish the facts of that specific case. So there is quite a bit of variation depending on that initial application.
Okay, thanks.
Okay, all right. So I guess my question is one for folks who are here representing birthing centers overall, that or others. How many applications are we looking at? Are we looking at folks who are very interested in going ahead and establishing birthing centers around the state where there may not be access to this kind of care? How many are out there right now? Does anyone have any sense of that? Probably not. Is anyone going to start one?
I could speak to that a little bit. I don't.
Terrific. Good.
I don't personally know any midwives who currently are planning on starting a birth center in Vermont. I think it's just common knowledge that it's not possible right now. So nobody is attempting it. I also would want to say that it's not a matter of whether there's pockets of the state that don't have access to this care. The entire state does not have access to this care. So it's not possible for it to be a duplication of services because there are no birth centers in Vermont, and it is a different service. As a midwife who works in hospitals, it is a different service to work in a birth center, to provide care in a birth center.
Okay, thank you. Michelle, you have your hand up.
I'm sorry, I'm not sure how I.
Okay, I'll come to you second. Thank you. So we have Michelle Wade has her hand up, and then we'll move over to your question.
Thank you, Madam Chair. When I was actually reaching out to multiple CNMs around the state, the reason that I was told by multiple CNMs that they were not actively pursuing at this time was because of the regulatory burdens surrounding a freestanding birth center.
Okay. Thank you. What did any of them give you an estimate of the costs for them to go through the regulatory process?
I did not ask any further than that.
Okay. Was it just simply, it was perceived as a burden, a process burden?
It was perceived as a process burden specific to the certificate of need and what they've seen happen with other entities that have tried specifically freestanding surgical centers, although this is a completely different entity.
I think so. I think you might
Can I
find it
speak?
different, but
I can answer that very briefly.
please do. Yes. Thank you, Lori.
Yeah, I think, I mean, I agree with Michelle in that if midwives knew that this was a possibility, there would be interest. That's why we have quite a lot of people, you know, who are in our working group trying to make this happen, because I think there's high interest. I just don't think anybody has a specific plan because
Right.
it isn't realistic at this point. If it became realistic, then I think there would be interest, but I don't think you would see half a dozen birth centers open in 2 years. You know, I think it would be a pretty, you know, a slow process. What I've observed, it takes minimally 12 months, probably, you know, more like 18 to 24 months to put the whole situation together. So, you know, I think you would see, you know, should I guess, likely the first place would be in the, you know, Burlington metropolitan area. And then, you know, once one is open, that gives a model and the understanding of how that might work to other people who might be interested. But I certainly would not anticipate that we, you know, in 5 years, we're going to have 10 birthing centers. You know, New Hampshire, who has a bigger population, has 5. And, you know, so
Yeah.
I think.
Okay. Yeah.
That-
Thank you. Lindsay Lashawn, you haven't been here the whole time. So you're here, and we did have you on the list of witnesses. And why don't you provide us some information? You have your hand raised. That's good. Provide us information. And if you have testimony that we can put on our webpage, that would be helpful. So Lindsay, welcome.
Thank you. Thank you for letting me speak today. My name is Lindsay Lashawn. I'm a certified nurse midwife and an international board certified lactation consultant. I want to speak to you about the difference between birth center care and traditional care in a hospital. And I strongly support the passing of S204 as it's written, as it will increase birthing options in Vermont. I come to you with 17 years of combined experience in maternity nursing and midwifery. Over the past 9 years, I've practiced as a midwife in several birth settings, including a large tertiary hospital, community hospitals, and a freestanding birth center located out of the state. I'm a member of the AABC, American Association of Birth Centers, and serve as a mentor for students completing the birth center assistant training. I reside in Southern Vermont, but currently work out of state in a hospital setting. I've seen the benefits of freestanding birth centers professionally as well as personally. I spent most of my midwifery career working at the only freestanding birth center in Connecticut. This was my dream job. I was able to provide the midwifery model of care, develop intimate relationships with families, and support healthy, low-risk people giving birth naturally with minimal intervention. This is the reason that clients came to us and sought out birth center care. Personally, my third baby was born at the birth center. It was the most satisfying birth because I felt well supported in a safe and welcoming home-like environment. I knew that I was going to get the exact type of care that I wanted without asking for it. The midwife provided ongoing, continuing care to us at home the next day, and we were lucky to have increased access to care during the postpartum period. I would have loved to have another birth center birth for my fourth and last child. However, we moved back to Vermont, where it was unfortunately not an option. The closest birth center at that time was 2 hours and 20 minutes away in New Hampshire. Since I didn't have access to a freestanding birth center, I gave birth in a hospital labor and delivery unit, which was called a birth center. It was not freestanding, and it was not the same experience. Like it's been said before, all of our neighboring states have freestanding birth centers. Vermont is only one of 2 states in New England without such a center, and these birth centers are a gaping hole in the Vermont healthcare delivery system. Some of the important aspects that differentiate birth center care include longer prenatal visits with time to develop a trusting relationship with the midwife, individualized care, education, shared decision-making. Midwifery focuses on the needs of the birthing person and allows the process to unfold while still monitoring safety, often called watchful waiting, and intervening only when necessary. Allowing this process to happen with the least amount of intervention protects the necessary transformation that occurs with birth. Evidence-based best practices allow for the best start to lactation and breastfeeding, which have a positive impact on long-term health for the dyad, reduced postpartum depression risk, and increases attachment and bonding. Perhaps the main difference in freestanding birth center care is the ongoing support and access to midwives during the postpartum period. In the early postpartum days, midwives do home visits and support the family in adjusting to parenthood, provide newborn care in the first month, and support lactation. There is ample evidence and research that supports that the birth center model is a community-based wellness model of care. It encompasses much more than the traditional maternity care that is limited to in-hospital care. It cannot be replicated in the hospital setting. The benefits of this model have been talked about. They include increased benefit to maternal and infant health, cost savings, improved experience of care. And these are all benefits that align with the Institute of Healthcare Improvement's triple aim. So this makes the option for midwifery and freestanding birth centers integral to improving the current maternity care system. And it's been said earlier that the current system is not working. Hospitals are closing. Birth centers can fill the gap. Services at birth centers offer, other than pregnancy, birth, and postpartum care, include routine primary care, uncomplicated GYN, gynecologic care, trauma-informed care, culturally competent care, and care for the LGBTQ+ community. Having a common place in the community for support and education, access to reproductive health services like birth control, improves and strengthens communities. Freestanding birth centers also provide equitable care and reduce racial and ethnic disparities. Lastly, there are unnecessary limitations to freestanding birth center care. The freestanding birth center of care is limited in part by regulatory barriers, inadequate insurance coverage or denials, and establishing birth centers to have the certificate of need requirement restricts birth centers and prevents this model of care, which is known to improve outcomes, provide equity in care, and reduce costs. The certificate of need process was created to prevent unnecessary duplication of healthcare services for facilities. But freestanding birth centers are not a duplication of service. There is a clear difference in the freestanding birth center model of care and the traditional medical model of maternity care in a hospital. Our current system is not working for us, and it's time to rethink and redesign care, integrating birth centers into the system. I know from personal experience and years of caring for families in the birth center model that this works. This option needs to be available to every Vermonter without unnecessary barriers, which is why I urge you to pass S204. Thank you so much, and I will submit the written testimony.
Thank you very much, Lindsay. That would be extremely helpful. And some of your comments we have heard, and so it's helpful to have reinforcement of what we've heard. Committee questions for the folks who are with us here today. It's been a long morning of testimony. So any final questions? I think Senator Hooker.
Thank you. I don't know who might have this answer, but what kind of data is there on births outside of hospitals in the state?
Whoever is not mute. Oh, it's you. Okay. Yeah, let's go first. Robin, did you have your hand up?
I just wanted to say that I did take a quick look at the Vermont Department of Health vital statistics, which has births by town. And so you can kind of figure that out because you can see that the town where a hospital is located has a much higher number of births than other towns. So you might be able to back into that information from the vital statistics.
Thank you. Dr. Fisher.
Senator Lyons, and I appreciate the question. It brings up an interesting point that we haven't talked too much about, and that is that Vermont actually ranks among the highest number of planned home births attended by certified professional midwives in the country. I think second or third behind Oregon and Washington State. To Ms. Lunge's point, yes, those data are very easily available through your maternal child health epidemiologist in Vermont. My last check, I believe something on the order of 4% of births in the state occurred in the home and were attended by the same licensed professionals that would be largely attending births in birth centers. So I think it gets to this idea that there's a zero-sum proposition that we're talking about. I don't necessarily know that that's true. Certainly some significant, I would imagine, percentage of people, birthing people who are choosing home birth would likely choose birth center birth. Lori Foster brought up the point that there are 2 birth centers located right on the border, right across the Connecticut River, that were opened by Vermont midwives. And certainly some percentage of their births are women who are traveling from Vermont to New Hampshire to be able to access that kind of care. So, and don't get me wrong, Dr. McGraw's points about the very challenging financial situation that hospitals are facing around provision of maternity services is very dire. But I think we would be remiss if we suggested that that consideration of an easier path to licensure for birth centers would undermine that in a significant way. I think it's a whole separate issue that's probably beyond the scope of this conversation or this committee as to how hospitals are reimbursed for providing maternity care. But I don't know that opening birth centers is going to substantively impact that dynamic, to be totally fair and honest about it. Thank you.
Thank you.
Okay, thank you. Any other questions? Senator Hardy.
Just a comment for Dr. Fisher. It's not actually beyond the scope of this committee. It's
Uh-oh.
part of what we're talking about kind of every day in this committee. So that's why I think you're hearing, this more broader perspective as we're trying to figure out the viability of our healthcare system at large. And so I think it's on our minds, and that's why.
Thank you, Dr. Thank you, Senator Hurdy. And I think while I am not a policy expert or an economist, you could potentially model, for instance, if cost of care for low risk patients was significantly lower in birth centers, perhaps that would free up resources to better reimburse hospital-based units who have to maintain that infrastructure that Dr. McGraw described, right? Maybe they don't need quite so many people if some amount of the lower acuity care were happening in a setting other than the hospital setting. Again, I'd love to come back and talk more about this. It's the basis of a lot of my academic work, and it's fascinating. But again, I think this idea that this is a zero-sum proposition is actually not true.
I'm sure you're right. I think that data we don't have right now to sort of look at the big picture and make that assessment. And that's why I was asking, Robin Lunge about, how can we look at this bigger picture and do that assessment? And it doesn't seem like we have the data yet, and that's frustrating, but it's certainly part of our work here in this committee.
Okay, any other questions? I guess I've gotten to a place now, Alina, unless you have a specific answer, a short answer, we're going to move ahead. Go ahead. Very quickly.
It's not an answer. I'm all right.
Oh, was it a question?
I kind of wanted to underline what's been said as far as we see that birth centers are having great outcomes, and we see that they're having lowered healthcare
We got
costs.
it. Yeah, we hear you. We hear you loud and clear, and we greatly appreciate everyone here who with their understanding and passion for birthing centers. We truly do. So I'm looking at my committee now for any additional questions for folks who are here. Senator Hooker?
Just one more, and I don't know if Jessa has some information on this. She referred to, hospital closings. What does happen when a hospital closes its birthing center and there's no alternative for women? I know that Dr. McGraw talked about picking up the clients from Springfield in Brattleboro. I mean, that's 36 miles from Springfield. So, what does happen?
Sure. Jessa Barnard with the Vermont Medical Society, and I see Dr. Fisher has his hand up, so he may be able to describe what's happened in New Hampshire more, where there's been even more closures. I know you're correct. In Vermont, it was the hospitals in the surrounding area that took on those patients, which did lead to significantly higher drive times. There was and then Brattleboro also, I think, has come up for, as Dr. McGraw mentioned, for the prenatal care, but for the actual delivery, they have to travel. So it has significantly increased travel and drive times to actual locations for delivery.
Yeah, Senator Hooker, they have to travel. We published a paper this past year looking at this issue in New Hampshire. Drive times doubled for women living in communities where the hospital-based labor and delivery unit closed. Those communities are disproportionately ones that face higher social determinants burdens. So the burden is falling more heavily on people already living in poverty. It's really not a great situation. We're looking at strategies to mitigate that, to ensure that people have access at least to prenatal care in their home community. But it's a very serious problem. It really is.
Okay, thank you. Laura Pelosi, I saw you come on screen. Did you want to comment? I know it has to do with Springfield Hospital.
Yeah,
and
no,
its
I think
financial. Yeah,
Jessa largely covered it. The Brattleboro Memorial Hospital are providing some services on site in Springfield. And I think to Dr. Fisher's point, the unsustainability of the reimbursement system for maternal care is a huge factor here for hospitals. And there's no question that providing those routine birthing services helps offset the cost and making sure that their birthing units are viable and available for patients that have complications. And we have to have those hospital birthing units available for those patients in particular. So I think, it's kind of a cart before the horse, I have to say. I think Certificate of Need can look at a lot of this. And I think, there's also a discussion around the sustainable reimbursement for these services so that hospitals can make sure that they're there to provide the services that are necessary in their communities for patients with complications. So the Certificate of Need process, I do think, is really critical in making sure that we're looking at hospital viability in terms of those birthing units.
Thank you. Okay, Senator Cummings.
You're muted, Ann.
I'm not, I usually don't mute in the afternoons. I guess my concern is getting very focused. Prenatal care is a lot easier to travel for if you do. Poor women don't have reliable vehicles, never mind vehicles with snow tires. I've been through experiences with cars needed to get a baby to Boston Children's. I've been through 2 weeks before I delivered my last child. A woman in Montpelier died in childbirth. And let me tell you, that sent ripples through the community. My concern is, and it comes to hospital reimbursement, making sure that in those times when things don't go well, that the birthing center has access to the emergency care that the woman needs in a viable amount of time. A 3-hour ambulance ride or a 2-hour ambulance ride, or having to go 2 hours for delivery services. I'm sorry, I hope we're training our troopers in midwifery, because a lot of people don't get that 2-hour leeway, especially with second, third children. I think my daughter did 15 minutes and she just had to get from Barry to Central Vermont Hospital. You know, and I'm just concerned about when we do this, who is responsible for setting up that system? Maybe it's a hub and spoke system, that we have birthing centers, but that there is a support at a centralized hospital close by that will provide the emergency services.
So you raise a really good point. It links in with the blueprint and the maternal paternal health program. So this is a conversation that we will have as a committee, and we'll have to hear from various folks about their thoughts on that, Senator. I think it's an interesting idea.
Well, to some folks, it's a life and death thing.
No, we get it. You're absolutely right. We don't want to leave people. We don't want our hospitals to die. We don't want people not to have the choices that they need. And we want to ensure that whatever is available as geographically across the state as possible. So I'm going to suggest that we close up for today, and we will be thinking about this bill and possibly bringing back some proposals for changes to the bill. We'll just have to see where it lands, but I think there's a lot of interest in the bill. I can't say there isn't interest in the bill. So we'll keep working on it. So